Hello, I'm Jonathan Kay from UMass Chan Medical School in Worcester, Massachusetts, reporting for Room Now from EULAR 2025 in Barcelona, Spain. Today, there was a clinical abstract session on prevention and early treatment of rheumatoid arthritis. Rheumatoid arthritis represents a heterogeneous group of diseases. There are patients who are seropositive with either rheumatoid factor, anti-citrullinated protein antibodies, or both. And then there are those who are seronegative. But these are not necessarily the only subgroups of rheumatoid arthritis. There's a need to identify distinct subgroups that might have different disease trajectories or respond differently to various therapies. There were two very interesting oral presentations at this session, both given by Tjardo Marversien from Leiden in the Netherlands, working with Rachel Knievel at that group, about subgroups of rheumatoid arthritis. They used unbiased machine learning cluster analysis of the Leiden early arthritis cohort and identified four distinct patterns of joint inflammation. Inflammation predominantly involving the feet, inflammation predominantly involving the hand, oligoarticular inflammation involving only a few joints, and then polyarthritis involving multiple joints. They observed in this cohort of patients with rheumatoid arthritis of less than 1 year duration that those with a joint involvement pattern involving predominantly the hand, those patients responded best to methotrexate, and those with polyarticular disease responded least well. Those with hand involvement were most likely to achieve CDI remission, and those with polyarticular involvement, as expected, would be least likely to achieve CDI remission. In this presentation, or in this study, they performed independent data meta-analysis of data from the NordStar and BEST strategy studies. The NordStar cohort included 812 patients with DMARD naive early rheumatoid arthritis, and the BEST study, a similar group of patients, 508 individuals who were randomized to four different strategies in each of these trials. They found that these joint involvement pattern subgroups were reproducible in each of these cohorts. Of these subgroups, the pattern involving predominantly the hand tended to be older individuals, and the pattern, which was polyarticular, tended to have higher disease activity both by CDI and DAS28-CRP. CDI improvement over 1 year was greatest in the hand predominant group and lowest in the polyarticular predominant group, with CDI improvement over time being worse in females, but independent of age, sex, serology, and symptom duration. CDI remission at 1 year was achieved most by individuals in the hand group and least by those with a joint involvement pattern being polyarticular. When they looked at the subgroup of patients in each of these studies who were treated with biologic agents, in NordStar with certolizumab pegol, abatacept, or tocilizumab, and in the BEST study with infliximab, they found that biologic therapies were similarly effective or ineffective for all joint involvement pattern subgroups. In the next presentation, Dr. Marversien went on to address the question, how do these joint involvement pattern subgroups correspond to synovial histology? What is the biologic basis for the distinct subgroups? To do this, he collaborated with Stefano Alvernini in Rome, who has a SynGEM cohort of 262 DMARD naive rheumatoid arthritis patients who underwent synovial biopsy of the knee. Now, in the hand predominant group or the foot predominant group, the knee is not necessarily the most involved joint, but the knee is most accessible for synovial biopsy. So they looked at synovial biopsies from the knees in patients, and they found that the same joint involvement pattern subgroups could be identified in this SynGEM cohort. They then looked at three characteristics of the synovial biopsies and found that the hand and polyarticular involvement group were relatively similar, with most severe lining layer hyperplasia, stromal density, and inflammatory infiltrate. These characteristics were least severe in the oligoarticular group and intermediate in the foot predominant group. So in this second study, they found that these joint involvement pattern subgroups appear to be distinct biologic entities. Now, the next step in proceeding toward personalized medicine will be to identify biomarkers that characterize each subgroup and might serve as predictors of disease trajectory. These two studies taken together help to characterize more homogeneous subgroups of patients with rheumatoid arthritis who might perhaps respond better to specific therapies and might be studied individually in clinical trials of novel therapies and also of existing therapies for rheumatoid arthritis. I look forward to seeing more coming from this group about this topic. I'm Jonathan Kay, reporting for RheumNow at EULAR 2025 in Barcelona, Spain. For more about this and other topics, go to rheumnow.com. See you later.